Hi guys, this short series of lectures is going to look at ventilation and perfusion. You will notice on the channel we have another series of lectures looking at ventilation and perfusion, but as I mentioned in class, that series of lectures is a little bit more basic than what we covered in class. So this series is going to look at ventilation and perfusion in a bit more detail. Of course, we start with a case, a 24-year-old asthmatic with shortness of breath who initially gets treatment, but it isn't as effective as it should be, and he's paralyzed and ventilated. When this happens, his SpO2 initially drops, even though his FiO2 is 100%. Just to finish the case, with time, that hypoxia corrects itself while the patient continues to be ventilated. We need to think about why this drop in SpO2 may have occurred and how that is related to ventilation and perfusion. So by the end of this lecture, we will discuss ventilation and perfusion in normal healthy lungs, describe the changes in ventilation and perfusion in some physiological situations such as exercise and changes in posture, look at ventilation and perfusion in a series of disease states, and then finally look at the effect of intermittent positive pressure ventilation on ventilation and perfusion. So let's start with the normal healthy erect lung, which is really the lung of a healthy individual in the erect posture, breathing through negative pressure ventilation, which is what we usually do. Usually when we breathe, breathing in is an active process. The diaphragm contracts, the rib cage muscles, the intercostal muscles contract and pull the rib cage up and out, and that increases the volume of the thoracic cavity, pulling air into the lungs. So inspiration is an active negative pressure activity. Expiration, on the other hand, is passive. When we stop breathing in and just relax, the lung goes back to its steady state. The steady state is really the volume, the lung volume at which the inward pull of the collapsing lung is balanced by the outward pull of the rib cage and diaphragm. And that is at the end of a normal expiration. So if we look at ventilation and perfusion, both ventilation and perfusion increase. So there's a gradient of ventilation and perfusion from apex to the base of the lung. This is greater for perfusion than for ventilation. Now, in undergraduate class, I think a lot of you may have got the idea that ventilation is highest at the apex and lowest at the lung. This is not true. Oxygenation is highest at the apex and lowest at the base, but ventilation increases from apex to base, and that's because the lung is more inflated at the apex and the rib cage at the apex is less mobile. So there is less change in volume of the apex of the lung during breathing compared to the base, where the increase in volume is due to movement of the diaphragm and movement of the lower rib cage. So ventilation increases from apex to base. Perfusion also increases from apex to base, and that's an effect of gravity. To perfuse the top of the lung, the heart has to work against gravity. To perfuse the base of the lung, it works with gravity. The perfusion gradient is greater from apex to base than the ventilation gradient. Therefore, ventilation perfusion ratio at the top of the lung favors ventilation, and even though the gradient increases for both ventilation and perfusion, there's a greater increase in perfusion. So the base of the lung, perfusion is favored. However, there is some matching from the apex to the base of the lung, because both ventilation and perfusion increase from the apex to the base of the lung. This sort of gives you the best correlation between ventilation and perfusion. So ventilation and perfusion are best correlated in the erect lung during normal negative pressure breathing. Although, having said that, the VQ ratio is highest at the top of the lung and lowest at the bottom of the lung. Because ventilation is greater than perfusion at the apex, there's physiological dead space here, and conversely, because perfusion is greater than ventilation at the bottom, there's some physiological shunt at the base. Remember, dead space represents an area of lung that is ventilated but not perfused, whereas shunt is an area of lung that is perfused but not ventilated. So what happens during exercise? Both ventilation and perfusion increase, but to varying degrees from the top to the bottom of the lung. Remember, in the normal resting state, ventilation is higher than perfusion at the apex of the lung. Now, both ventilation and perfusion increase at the apex during exercise, but as we said, the apex is already fairly hyperinflated, so there's less increase in ventilation, whereas there's more increase in perfusion due to vasodilation of the apical vessels and an increased cardiac output. If perfusion is increasing to a greater extent than ventilation, that would balance ventilation and perfusion, because remember, the rest state at the apex, ventilation is greater than perfusion. The opposite happens at the base. During exercise, we have a maximal increase in ventilatory capacity at the base of the lung because the diaphragm is moving more, all the intercostal muscles are moving, and the base of the lung, the rib cage, is where we can get maximum movement of the lung. So there's a greater increase in ventilatory capacity at the base of the lung during exercise, whereas there's a lesser increase in perfusion, although there is an increase at the base. And remember, in the resting state, perfusion is greater than ventilation at the base of the lung. Because in exercise, ventilation increases more than perfusion, there's more of a match between ventilation and perfusion. So with exercise, both at the apex and the base of the lung, there's better matching of ventilation perfusion, and there's an overall increase in ventilation throughout the entire lung and in perfusion, both of which increase gas exchange and the blood flow through the lung. What about in the supine position? So in the supine position, there's a slight difference in the way ventilation and perfusion are affected. Remember, ventilation is greatest at the lung bases and least at the apices, and that relationship remains more or less in the supine position, although ventilation is somewhat hindered because of the weight of the abdominal organs on the diaphragm. So the diaphragm is not going to be moving as easily as in the supine position. But there's still a slight increase in ventilation from the apex to the base. And similarly, there's an increase in ventilation in the anterior part of the lung. In the posterior part of the lung compared to the anterior part of the lung, but that is not as marked. So from the anterior to the posterior part of the lung, there isn't a lot of change in ventilation, and there's still some variation between the apex of the lung and base of the lung because of what we spoke about before. There's a more marked change in perfusion, however. Because of the effects of gravity, perfusion to the posterior part of the lung, which is now dependent, is greater than perfusion to the anterior part of the lung. If you think about this, what that means is that there is more mismatch of ventilation and perfusion because there's less variation in ventilation in the supine lung, but there's still a variation from the anterior part of the lung to the posterior part of the lung in the supine patient. So there's an increase in ventilation perfusion mismatch in the supine patient. Adding to that the minute volume is decreased in the supine patient. Okay, so we'll stop there for this first lecture. If you have any questions, you can bring them up in class. So today we talked about ventilation perfusion matching in the normal lung. In the next class, in the next lecture, we'll look at ventilation and perfusion in certain disease states, and then finally we will look at positive pressure ventilation.